Okay, I'm Dr. Brian Lancaster. I'm one of the primary care sports docs here at OCR. I've been with the group for about 5 years. And today we're going to be talking about intro to ultrasound of the shoulder. So this truly is an intro session. The main goal here is really to get some hands-on experience doing a little bit of ultrasound with regards to the shoulder. So I'm going to try and keep my slides here very brief. And as you can see, we have multiple spots around the room that after I'm done talking, go ahead and just pick a table, and our wonderful models are going to allow us to ultrasound their shoulders today. So I also apologize that we don't have CME credit for this. My goal is, in addition to getting you the hands-on experience with the ultrasound, is if this goes well and you feel like it's helpful, we may expand it in the future, and then with that I think we can actually get it accredited. But if you like it, let me know, or if you have any criticisms or questions or anything, please come up to me after the session and just let me know how we can make it better, or if you liked it, like I said, and hopefully we can expand it to multiple joints and things like that in the future if it is helpful. So how many folks in here are currently using ultrasound diagnostically or in any capacity in their practice? Is anyone doing any? Perfect. Okay, good. Awesome. So that's what we want. Okay, so just very brief overview of the shoulder. So we're going to, the brief shoulder anatomy here, really with the ultrasound divided into 4 different sections. It's going to be anterior, it's going to be lateral, posterior, and then superior. So anteriorly, we're going to look at the supraspinatus rotator cuff muscle. We're going to look at the long head of the biceps tendon. So we want to see both of those structures in that region. Laterally, we're going to look at the supraspinatus, and we're actually going to look at it in a couple different positions because you can see it pretty well in a modified position. It's difficult to do in just the standard anatomical position. And then we'll move posteriorly, looking at the infraspinatus, and while we're back there, you'll actually see the posterior glenohumeral joint as well. Sometimes we pick up a little bit of the labrum with that. And then we'll finish with the superior aspect of the shoulder and look at the acromioclavicular joint. So I'm going to give you a brief rundown here. We have all these slides and handouts for your reference as you're trying to scan. And then as we're scanning, I'll be coming around the room and hopefully giving you pointers, answering questions, helping folks out. So subscapularis is going to be the first thing we'll look at anteriorly. Anytime we look at a muscle tendon group, you want to look at it in length with the muscle as well as the tendon. And we call that the long axis. If you flip the probe 90 degrees, we'll call that short axis. That's what we've used as a nomenclature or terminology for ultrasound for quite a long time, but you can also describe it as we would in the typical anatomic planes, whether it's coronal, sagittal, or axial. But so we'll look at it here in the picture. Here we have it in the short axis, so cross-sectional view, and then flip it 90 degrees. And long axis, you should find it inserting on the lesser tuberosity. And then in the short axis, when you see it in cross-sectional view, you might be able to pick up these 3 fascicles, or three muscle bundles, I should say, that make up the tendon. So if you see those 3 bundles, you know you've got the subscapularis. While we're there too, you'll move just slightly medially into the long head of the biceps. What you're really looking for is this groove, or this little saddle here that the bicep sits within. Seems pretty obvious, but not everyone, and even myself when I'm doing some of our diagnostic procedures, actually see that bicep so well. So if you're not sure whether or not it's the bicep tendon, just go ahead and fan the probe a little bit, little micro movements, and it should go from light to dark here. And that's how you know you have a tendon. Tendons exhibit a property called anisotropy, meaning as the ultrasound waves are directly over the tendon and bouncing back, when the probe's directly perpendicular to the tendon, it'll show up as bright white. If you fan just a little bit, it'll go black like this. That's how you know you have the tendon. Might see fluid around the tendon like this too. If they've got some pathology there. Once you've centered the tendon in the screen there, and you found the saddle, you've seen it in cross-sectional or short axis view there, then just flip the probe 90 degrees and we'll find the tendon in long axis here within the groove. This is how we do our biceps tendon sheath injections. So we'll have the patient laying down and inject them in the axial plane or short axis. Again, finding that saddle here and then bringing the needle in from the side. And I can kind of point out how we do that if anyone has any questions with it. Then we'll move to the lateral shoulder. So in neutral position, so patient facing forward, hand up, or forearm or hand supinated here. You'll see if we put the probe in line with the supraspinatus tendon. We'll see it inserting on the greater tuberosity here, but you'll notice this kind of shadowing here. That's the acromion. So we don't really get a full view of the tendon. We can't follow those fibers because it's kind of hidden under here. So in order to better see that, just ask your patient to put their hand on their hip here, and we'll roll the shoulder forward, and that will reveal or bring the supraspinatus out from under the acromion there. And then we can see it better here, so we see more proximal fibers of the supraspinatus, and then more distal as they insert on that greater tuberosity. And then here we'll see it in short axis or cross-sectional view, and that's what's demonstrated over here. So if you're really good with your ultrasound, you might pick up a supraspinatus tear like this. One of the most common rotator cuff tendons to tear. And I don't know that I've ever seen it look this good, but if you might get lucky and pick up one of those full thickness ones. And this is going to be in the long axis, and then this is short axis looking through there. And then subacromial injections are sometimes done in this plane. I don't really use ultrasound so much for subacromial injections. It's pretty easy to get to that area with just landmark guidance, but if I am doing guided procedures like PRP into the tendon, I will use the ultrasound and bring it in this fashion. For the posterior joint, we'll move posteriorly, right? And we're going to look at the infraspinatus here. We'll look at it. This is the long axis here. You'll look at it short axis as well, just like we did with our other muscle and tendons. Deep to that, you might find the humeral, you should find the humeral head here, and then the glenoid adjacent to that. These arrows here demonstrate the labrum. We don't really use the ultrasound for diagnosing significant glenohumeral pathology. You might get lucky and pick up something like a posterior paralabral cyst if they've got a posterior tear and you've got enough fluid tracking into the tear, around the tear. But really, I use this more so for our ultrasound guided procedures. So particularly glenohumeral injections can be done in this fashion, where you bring the needle in plane with the probe here. You have the probe in the axial orientation posteriorly and coming into the joint there. There's other ways to do it. In fact, I do it a different way more of the time, and I can explain that more as I kind of come around, but we want to get you guys scanning. So, and then finally, let's go superiorly. We'll go to the acromioclavicular joint. So we'll bring the probe over the top of the shoulder there and put it in what's essentially the coronal plane. You'll see the end of you should find the end of the clavicle and then the acromion as well. And then between, you see the joint fluid here. This is the joint capsule overlying that. In patients that have significant AC or pathology like AC arthrosis, we'll see this kind of expands, looks like a big mushroom over the joint, makes a really nice and easy target if we want to do something like an injection. This is one method of doing the injection into the AC joint. So we have the probe in the coronal plane, and they're coming in laterally. When you have a relatively healthy AC joint, that's pretty easy, but if you got a lot of osteophytes around the area, can be difficult to get it in. So oftentimes what I'll do is I'll come out of plane actually from the center of the probe, have it lined up directly over the center of the joint, and then just pop straight in. So I know that was kind of a whirlwind really fast, but the point here is I want to get everyone scanning. So let's go ahead and do it. Find me if you have any questions or any comments.